5 o'clock is it? 5 in the 5 2 minutes. Yeah, then I will wait. Still 2 minutes time is there. What will be the screen? 5 o'clock is it? 5 in the 2 minutes. Yeah, then I will wait. Still 2 minutes time is there. మీకు వస్తుంది అక్కడ క్లోజ్ చేయాలి. So we will go for the first program of the pure urology on the Facebook group focused on the surgical techniques. This is primarily for the urologists only. As you all know, last few years we are doing most of the learning and education through the electronic media because of the corona, social media. In the same line, we started this group Pure Urology. Only difference is we are trying to focus only on surgeries, surgical techniques or any complications related to the surgery, as we are primarily urology surgeons. This is our first program. The talk will be delivered based on the surgery videos. The speaker is Dr. Ravindra Sabnis sir. Dr. Ravindra Sabnis sir is actually present President-elect Urology Society of India, and he is the chairman and head of the department of Urology Department, MPUH, Nadiad. Most of the Indians and across the world also know sir for his endourology work, his academic interest, and as a teacher. Keeping these 30 years of his vast experience into consideration, it is my honor to start our program first with Sabnis sir. Personally, for me, after I finished my MCH way back 15 years back, nearly 12 to 13 years of sir's encouragement in the urology made me to learn new things, particularly at MPUH. In fact, I started my first learning in 2007 at MPUH under sir and Dr. Mahesh Desai sir. Since then, we continued our relationship and learned lot of surgeries, including laparoscopy, from MPUH. Sir is actually council member once, was West Zone Urology Society of India, Honorary Secretary West Zone, President West Zone, Board Member, Board of Education USI, which was started by Sir Idea. Is was the chairman also for Board of Education, which is presently Indian School of Urology, Council member of the Urological Society of India, Honorary Secretary of Urological Society of India. He has more than 100 publications. Probably now it might have become 200. 9 book chapters and 1 book, more than 200 lectures, more than 50 live surgery demonstrations. Best paper publications award by BJU in 2014. Best teacher award by NBA for year 2018. Best expert review award by SIU for year 2018. The best was in 2019, where he received a Global Leadership Award by American Urological Association. With this introduction, without wasting time, actually this presentation we will restrict to 20 to 30 minutes. That's what I requested Sabnis sir. Let us hope it will be useful for all of us. How to puncture during PCNL or miniperc, and where we can go wrong. During this talk, he will concentrate on all the types of monoplanar, biplanar, ultrasound guided, bullseye, etc. So now I will hand over to Dr. Sabnis sir. Thank you, Sabnis sir, for accepting the invitation. Over to you, sir.
Well, thank you, Chandra Mohan. It's my great honor, privilege to be the part of this first program. And I must congratulate you for making this Facebook page and the sheer enthusiasm of the people, the kind of work which you have already done in Facebook, and your so many techniques and videos which you share with people time and again with the various social platforms. The more than 700 people have already joined in less than 24 hours. So that's a kind of faith people have put in your creation. So I must congratulate you. This pure urology is a very nice concept where you are devoting this whole Facebook page only for the surgical technique. And many times we see that in the conferences and other things, people present statistics, series and percentage and this, that. But where the people lack is the sheer small aspects of surgical technique. And I think this Facebook page over a period of time will be of immense benefit to the people who really need it. So I must congratulate you, and I also must thank you that on the day one of this program, you have selected me, you have given me this honor. I'm really thankful to you. I'm sure over the period of years, maybe 5 years, 10 years down the line, when the history of pure urology will be written in the Facebook, that it will be written that first lecture was delivered by me. So that's an important milestones which you have given me the opportunity to have. So I'm extremely thankful to you for this wonderful opportunity. As Chandramohan said, I'm going to talk only about the puncture, the technique of puncture. Many people still face the problem of technique of puncture, and I'm going to elaborate in next 20 minutes about the puncture. There are a few things which one has to understand before you start making a puncture for PCNL, is that what appears simple may turn out to be very difficult. And this we have experienced in the last 30 years. And I'm sure everybody who are doing PCNLs, we have understood that sometimes it looks so easy, but when you actually start doing it, it becomes very difficult. At the same time, sometimes the things which appear very difficult, they turn out to be very simple. And I've seen this so many times in various live surgery demonstration, where we have discussion before starting the surgery that, okay, this is a problem you can face, this is a calyx which is difficult, and there's a compact calyx and this and that. And eventually when you actually start doing surgery, things turn out to be very simple and very easy. So that actually keeps happening. And why that keeps happening, I will tell you sometime later. Now, for that to understand that why such things happen, you need to have a very good judgment. Puncture is the part of judgment. If you get the judgment, your puncture is actually a child's play. And therefore, there is no shortcut for that good judgment. You have to have experience. You have to do a number of cases for you to get that good judgment. So judgment comes only from the experience, but experience comes only after the bad judgment. So it is part and parcel that if something goes wrong, if you fail in puncture, if you make multiple attempts, it's not something which is harmful. In fact, you are learning from each and every attempt of your failure, each and every bad judgment which you have taken or which you have implemented. You are learning from that, and your experience is increasing. And as your experience will increase, your judgment is going to become better and better. So sticking to this is going to be an informal talk, which Dr. Chandramohan told me very clearly. This talk is going to be only on the video based. There is no percentage, there is no statistics, there is no series, there is nothing like meta-analysis and things like that. But at the same time, the topic of puncture is extremely vast. There are so many aspects about puncture. In fact, we can have a whole day conference for restricting only to the puncture technique and puncture problems of the pelvic calyceal system. So topic is very vast, but I'm going to restrict myself only to 20 minutes, and I will highlight most of the problems which you face and what exactly you should achieve the puncture. Well, there are many techniques which have been described: bullseye technique, triangulation technique, pre-landing technique, monoplaner technique, USD guided. There are many techniques, but whatever is best in your hand, continue to do it. If you are achieving a good puncture with a particular technique, which may not have any name, but your own technique, don't change it just because somebody else, some expert is doing in some other way. That is not right. That's why I said that in a puncture, you must have a good judgment and your own technique, and follow that technique repeatedly. So you will get the idea. When you want to do the puncture, the most important thing which come in your mind is identifying the posterior calyx. Now that is where many people face problem. Well, if you see the AP view, which is where we keep the fluoroscopy like that. Now, if you see, this is the kidney, this is a spine, this is the muscle, this is the kidney, how it is lying in the prone position. This is a posterior view, this is the anterior calyx, posterior calyx. And in the AP view, it will appear as an end on. It is not going to appear like this. And therefore, this blotch which you are seeing actually is the posterior calyx. So this is exactly appears like that. And the remaining calyces which are seen here, they will appear the anterior. So in a fluoroscopy, moment you do RGP, what appears as blotches here in the kidney, they are the posterior calyces because they are the end-on shadows. So this is a very important factor to understand what is anterior and what is posterior calyx. The next question is that why you want to identify such calyces? What is the problem? So that is what I'm going to address in my talk. Now you see this is the RGP. This is how the pictures will come and how you identify the calyx. This is the upper posterior calyx. These are all offshoots of the anterior calyces. Okay, so this is the posterior calyx. This is the posterior middle calyx. This is the anterior calyx of the middle calyx, anterior and posterior. And this is the lower posterior calyx. This is the anterior branch, and this is the anterior branch. So when you do RGP and when you are puncturing the kidney in an AP view, you need to target. If you want to go from here, you have to target here, not here, not here, not here, but you have to target here. You have to target here. You have to target here. If you target here, you will still puncture. There is no problem. But that's an anterior calyx, and that anterior calyx is problem in the prone position. I will elaborate on that a little later. So this is what you need to identify, and that's a very important factor. So identify a calyx on the RGP, which you know is the posterior calyx, and once you make that puncture, then your subsequent procedure will be easy. Technique of access to the kidney is very important because that will decide the success rate. If your puncture is properly done, your half work is already done. Now you see this incorrect puncture. Why it is incorrect puncture? Now, why it is incorrect puncture is because if you see this, why it is incorrect? The RGP is there. This is the calyx. This is the calyx. This is the calyx, and you are going actually through the portion which is in between calyx. So it's a direct pelvic puncture, not going through the calyx, and that is not a correct thing. Because there are many problems of going directly through the pelvis. not going through the calyx. So that's a very important thing. There are major vessels which are there. Your inability to manipulate inside, your dilatation will have a problem. So there are many problems, and therefore direct pelvis puncture is to be avoided. And therefore, when you puncture and when you get the fluid, doesn't mean that, oh yes, great, everything is achieved. No, it is very important for you to understand by putting the contrast that how exactly you have achieved that puncture. So getting into the kidney is not important, but how you got into the kidney is very important. So this we know is an incorrect puncture. So now what is a correct puncture? So identify, this is a posterior calyx here, this is a posterior calyx here, this is an anterior calyx. These are two anterior calyces. So either you target here, you target here. These are all tiny calyces. You know, this is undilated system. Calyces are not dilated. It's not going to be an easy system to puncture. So you need to make sure that you are targeting into the posterior calyx here. And once you target the posterior calyx, then your entry point is proper, and that becomes a absolutely correct puncture, which is through calyx, which is through the posterior calyx. And then whatever you want to do, manipulations inside the kidney are absolutely all right for you to do from this calyx. Now again, look at this video. What is, it is incorrect puncture. Why it is incorrect puncture? Because you have punctured it properly, you got a proper fluid. You have done it in the first shot, no problem. But moment you put the contrast, you see that how the contrast has gone in. Let us see this video again. This was a stone here. You see, this was a stone here. You have punctured it, you got a fluid, you have put a contrast. Now, this is a stone, your contrast is going into the anterior calyces. From here, it is going into this calyces, then pelvis is visualizing. So this stone, which was in the posterior calyx, actually you have not gone into that calyx at all. You have directly gone through the infundibulum into the anterior calyx. So this puncture is not a proper puncture. If you continue with this puncture, what will happen? First and foremost, it is through the infundibulum. There will be problems, vessels, bleeding, and things like that. Secondly, even if you don't get that problem, not that every time you get this problem, but as you go inside, you will be actually going through into the anterior calyx, and from anterior calyx, once you put a scope from here, once you have to go into this stone which is in the posterior calyx, will be extremely difficult. So you will dilate, you will put a scope, and then you will realize that you are not able to see the stone at all. As you keep withdrawing, you will withdraw the scope. It will come through the up to the infundibulum. After that, you will go out of the system. Suddenly, the bleeding will start. Suddenly, the vision will not be clear, and you will see a small something which is here, but you are not able to manipulate that inside. So this is a problem which you anticipate if you have this sort of a puncture. These are all problems which will come. So just getting the fluid and getting into the pelvic calyceal system in this manner is not appropriate at all. This you need to discard. This is not a proper puncture at all. So what is proper puncture? This is a proper puncture. Why it is proper puncture? Now you see that this was the posterior calyx. This is the rest of the system. This is the small anterior calyx here. This is the dilated anterior calyx here. Now your needle is going directly hitting into the posterior calyx. The stone is there. Now moment you put contrast, it is going, visualizing this posterior calyx, going into the system, going into anterior calyx, and that is how the system is getting visualized. See now, as we are putting contrast, this is getting visualized, this is getting visualized, and everything is visualizing subsequently later. So now if you put your wire, it is not going to get coiled up here. If there is a space, it will actually go into the pelvic calyceal system. If the calyx is very compact, if there is not much space, you will have difficulty in putting wire. But your puncture, you know, is absolutely accurate, and this is from this, you will directly go onto the stone, and once you clear up the stone, moment you tilt your scope, you will see all this dilated anterior calyx, here calyx, and from here you will go into the pelvic calyceal system and you will see the PUJ. So the puncture which was previous in the same system was not proper. Withdraw that needle and make this puncture which is correct, and that is how you must do the access to the pelvic calyceal system. Now, quite a bit about the monoplanar puncture. Now, what is monoplanar puncture? There is nothing. Generally, what you do is that you make a puncture in the anterior AP view, And then if you think that everything is fine, then you rotate the C-arm to 30 degree and take the perception of the depth. Depth is anterior or posterior. And that is how you adjust. If it is not proper, then you withdraw the needle. If you are too superficial, go deep. If you are too deep, go superficial. So this is how the normal fluoro-guided puncture is done. But as you become experienced, you understand by judgment that whether your depth perception is proper or not. So monoplanar puncture is nothing but the same puncture. You keep the fluoroscopy in the AP view, and you take the depth by your judgment. Now, if you make the judgment, that is by your experience, you know whether you have hit the pelvic calyceal system or not, and whether you are in the system or not. Often, by your own judgment, you understand that although it appears quite good in the AP view, you are not hit the pelvic calyceal system. By your own experience, you can do that. And there are certain clues by which you understand that whether you are in a proper system or not. So what are those clues? Now you see here, now I am targeting this posterior calyx here. I am advancing needle. Now see what is happening, that as I am advancing, the needle is actually pushing, and the target calyx is actually going forward. There is a buckling of the kidney. And as you keep on pushing the needle, the calyx is going forward in your own needle direction. So that's a very important sign. Now you see again that this is how you advance the needle, and the target calyx is going forward from your needle. So that means your direction is proper. Now this movement is, I'm making this movement. What is this movement? Again, see again. Now once I feel that I'm in the system, now I'm making this movement. And once I make this movement, what happens is that this needle which I am moving from here, it is not going beyond the boundaries of this calyces. You see, that's a very, very important sign. If you are not in the pelvic calyceal system, it is possible that your buckling, the motion will come, the calyx will keep on forwarding, but you are just few millimeters away from the pelvic calyceal system. But when you are doing that, before you take out the stellate, you can make this idea, if your needle is going beyond the boundaries of this pelvic calyceal system, you are certainly not in the system. You don't have to even withdraw the stellate and see whether fluid is coming or not. You are certainly not in the system. But if you make the needle movement here and there, and every time it is not going beyond the boundaries of the pelvic calyceal system, which means that you are likely to be inside. Let us see that again. Now let us see all this again. Now you see step by step. Kidney is moving, calyx is going forward. So I'm in a proper plane. I'm puncturing. I got the give way. Now I'm making the movement. It is not going beyond the boundaries of this pelvic calyceal system. So before I withdraw this stellate, I am quite more or less sure that it is a proper puncture. Then you withdraw the stellate and see whether fluid is coming or not. In case if you want to really see, you rotate the C-arm and see whether you are really properly in the system or not. No harm in doing that. But quite often, as you keep on getting experience, you will not require to rotate the C-arm to 30 degree. With all this trial and error, all these movements which you observe on fluoroscopy, you will be able to make out whether you are in the proper system or not. So that's a system, that's a monoplanar this. Now, the other thing is that the other method is the ultrasound guided. Often ultrasound guided, there is a lot of debate which happens. The practical point is that when you are having ultrasound guided puncture, you must have this puncture attachment. Quite often, people will show you that, okay, I just put ultrasound and then by the side I put the needle. That is technically not the purely ultrasound guided puncture. It is still becomes a blind puncture, because the benefit of the puncture needle is that when you have this puncture line, and when you make this puncture line on sonography in such a way that it goes through the calyx, now once you adjust it is on the screen, then from the puncture attachment, if you thrust the needle, it is bound to go in this line only. So you have no thinking of anterior, posterior, depth, is that, nothing. Your idea is, your objective is only to bring this line into the target calyx. Once you get into that target calyx, your job is over. Just thrust the needle and that's it. The job is over. It is going to go like this. So this is what is the ultrasound guided needle. But it is not as simple and as clear as what it is being shown. Now see here what is being done. This is how you take the ultrasound probe, come from the backside to the this. The calyx which comes first is the posterior calyx. Now you see the kidney, how the kidney is looking. Whichever target calyx which you want, whether you want this calyx, that calyx, you bring into this dotted line. This dotted is a puncture line. So by making movements of the probe here and there, anterior, posterior, angulation, this, that, your dotted line has to come into the line of the target calyx. And then you thrust. Now you see that this was the calyx which you have thrust. This is the pelvis. And once you thrust that, it is bound to go into that calyx. It is bound to go in that direction. And once you withdraw the stellate, you are going to get the fluid. So in ultrasound guided puncture, your imagination actually goes away. You don't have to really imagine what is going to be the depth, what is going to be the anterior, posterior, this, that, nothing. Your job is by making a movement of the ultrasound probe in such a way that dotted line comes into the target calyx line. That's it. Once you get that, hold the respiration and just thrust the needle. It is bound to go there. So this is what is the ultrasound guided puncture. So now at the same time, it is not that easy, because sometimes what happens is that although this is a properly made ultrasound, same way you have seen this calyx, you want to puncture that calyx, needle has come, needle goes inside. But see what happened, that needle actually has not gone into the calyx, through the calyx, it has gone through the infundibulum. This was a transplant kidney, wanted to make a puncture. But if you pursue with this sort of a puncture, which is not a correct puncture, then you are going to land up with the problem. So you have to go through this calyx, or this calyx, or this calyx. And that is what happens. Now, the next question is that even though you make it ultrasound guided puncture, why it has gone outside? Now, there are a lot of things about it. Even though your target calyx was proper in the dotted line, but what happens is that because of the tissue resistance, and especially when we don't use the new needle every time, new needle is very sharp. But when you reuse it, the sharpness goes away, the tissue resistance actually comes into the play. And that's why the needle does not exactly go into this line. It gets deviated a little bit by few millimeters. Now you see here that this was a needle. This is a little bit away, but that deviation is because of the tissue resistance. So you withdraw it and make it another puncture, go into the proper calyx. Now, because there is a resistance, this happens, but benefit of the ultrasound guided puncture is that more or less you are there. Now you just have to make a little bit, few millimeter movements here and there, which you can make under fluoroscopy guided, and then achieve the proper puncture. So this is what is the benefit of the ultrasound guided puncture. Now this is again a video of the ultrasound guided puncture. See here, you can see that make the movement, make sure that the thing is properly done. Your movement of the probe has to be there. Once you make the movement of the probe, you see the target line, you see this is the target calyx. And now you make this puncture. This is perfectly gone into the calyx, exactly there in that line. And once you see that needle, it is bound to be in the pelvic calyceal system. One can see again that this is how you make a thrust. Now, important thing when you are making ultrasound guided puncture, or for that matter, any fluoroscopy or any puncture, is to go inside in one thrust. You see now, this is a dotted line. I'm thrusting the needle here. It has exactly come here on sharp, exactly on the dotted line. Once you know that it is a movement which is, you can actually see everything, and then your job is over. So that's the benefit of the ultrasound guided puncture. Often you will see that you have made a proper puncture, but there is a blood on the puncture. Sometimes you inject fluid from the ureteric catheter, and sometimes it clears up. You think that it has cleared up. If it completely clears up, no problem, go ahead and utilize that puncture. If on the injecting contrast, if it is a good puncture. But if it clears up transiently, again there is a blood stain, again it clears up, again it blood stain, discard this puncture. What it suggests that in the process of puncturing, you have hit some major vessel, major in the sense not a big vessel, but a significant size vessel, and you don't want to continue with this puncture, because puncturing is no problem. Once you start dilating this tract, whatever dilatation size you want to dilate, this is going to create a problem. So puncture you can definitely achieve. So don't accept this suboptimal puncture. Don't accept puncture which is having blood stain. The other problem in the puncture is the zigzag tract. That's what I was elaborating about the zigzag tract. What is zigzag tract? That, as we saw here, that in the AP view, this is a posterior calyx, this is the anterior calyx. Your target is to puncture the posterior calyx. Now, once you get a posterior calyx, you can see the pelvis, and from here down, you can go into the anterior calyx in a prone position. Why you want to always puncture posterior calyx? Because in a prone position, as you sit down, this is the anterior calyx. If you make this puncture into this calyx, and if there is a stone in this calyx, in a prone position, it is very difficult to see what is above at 12 o'clock. You can always go at 6 o'clock, 5 o'clock, 4 o'clock, like that, 7 o'clock. You can always see, because that's a natural position of a spool. But if there is a calyx which is coming out at 12 o'clock, it is very difficult for you to go into that calyx. And therefore, in a prone position, it is very important for you to make a puncture into the posterior calyx. At the same time, it is not the gospel truth that whatever come what may, you have to go into the posterior calyx. Suppose the whole burden of the stone is in the anterior calyx, there is nothing here, then it is not appropriate. You may not be able to go from posterior to anterior. You may have angulation, acute angle. So in that case, you just hit the stone, whichever calyx it is. Forget about that, because your target is to get the stone out. So hit this stone, whichever calyx it is, dilate that, and then you clear up the stone, because now you know that it is not the multiple stones which you have to go from one calyx to other calyx and this and that. So that way you can clear up. But the other thing, important thing, is to go in one thrust. Otherwise, what will happen is that your puncture will become a zigzag tract. Now, what is zigzag tract? See this, you have made a puncture. You want to make a puncture. You have withdrawn the needle. The puncture was not proper. Now you have changed the idea. You have gone here. You have got the fluid. You have got into this. Now, once you withdraw the needle, which is rigid, the guide wire takes the shape of a tract, which you have made the movements. Now, if you take this movements, this is not a proper, because this is a zigzag tract. You have to go up to this point, again angulate, again go here, again angulate, again go into the system, again here. Now again you withdraw this. Now once you do that, then this part is under torque, under severe tension, and that will definitely cause bleeding. And therefore, even though this is not a proper, this is just demonstration of anterior calyx, what are the problems? Even when you are the posterior calyx, if you go from here up to one point, then again rotate your needle, go here, same problem will take place. And therefore, when you want to make a puncture, it should be a straight tract. It should not be a zigzag tract. It should be as short as possible, and it should be achieved in one single thrust. Don't just go a little bit inside, again go a little bit inside, again change angle, again go a little bit inside, again change angle. This will create multiple zigzag tract, which is not proper. Instead, you pierce the skin, see for the calyx which is targeted, stop the respiratory movements for this, and one single thrust, just go inside the calyx, and that will become a straight tract, which will be an appropriate tract. So your puncture has to be proper in such a way that you should not create a zigzag tract, which will spoil the whole subsequent surgery. Okay, so I think 25 minutes are over. This is in short about the short technique. As I said, the puncture is not a small topic. there are so many aspects about it. How to make bullseye puncture, how to make a puncture in the kyphoscoliosis, how to make the ectopic kidney, horseshoe kidney. There are so many aspects. How to make the change of the position of the siam, whether it is to be rotated by side, whether it's to be rotated by craniocaudal. There are so many aspects about the puncture, but keeping the time factor into the aspect, I thought these are some of the technical aspects which may be relevant for the people to watch, and that is why I just collected the videos. It may not be that perfect because it was just the short notice, and whatever videos I had in my record, I just collected the videos. But thank you very much, Chandra Mohan. I suppose in the first inaugural talk, I have done justice to this talk.
Yes,
Thank
yes.
you, and over to you.
Sir, thank you very much, sir. To be honest, a lot of times this illustrative video, last one is very interesting, where this zigzag tract. You have really taken it a very 25 minutes. I thought still some more time is there. I want to listen, but you have stopped it here. I want to ask 10 brief questions so that we will close the session, sir. Sir, when there is a post-operative case of PCNL or open surgery, you puncture, there is no problem. You passed a guide wire, and when you are doing dilatation, if lot of resistance is coming, what are the tips you wanted to give, sir? Lot
Correct.
of resistance.
Correct.
What guide wire is better? What dilators are better?
Yes. So in a post-operative period, post-operative case, either open surgery or previous multiple punctures and that, there is an intense fibrosis. The kidney gets fixed up. Kidney is not mobile. Kidney gets fixed up because there is a lot of fibrosis around the kidney. And in that fibrosis, even though you make a proper puncture, it is very difficult to dilate through that tract. And in the process, you try to force your dilators, and then suddenly you go through and make a medial wall puncture. And if you don't make a forced puncture, you don't actually achieve the dilatation at all. So that is a problem which you face. So there are a few things which can be done on that. One is that the make a skin and subcut and the tissue with the 11 number blade deep inside. Once you make a puncture, and once you pass a guide wire, once you pass a first dilator, or you pass this, make a proper liberal cut with the 11 number blade. So that will cut about subcutaneous and little bit depth of the subcutaneous tissue by that. So at least your first 1 centimeter of entry of the dilators becomes easy. Then in the fibrous tissue, it is not appropriate to make a single tract dilatation, and in one stage dilatation. You pass a 6 number, you have to use the rigid dilators, 6 number dilator, 8 number dilator, go in a sequential manner, put the guide rod, use the telescopic dilator system, Alkin's telescopic dilator system. We generally do a single step dilators, but in a post-operative case, often we end up in using telescopic dilator system, Alkin's this, which actually gets dilated very well. The choice of guide wire is very important. When you are making these movements, if you use Terimo glide wire, it will slip because your attention is on the dilatation. Assistant is looking somewhere else because he is under tension because you will fire him. And in the process, the guide wire slips out. Nobody understands when the guide wire has slipped out. So in such situation, use the zebra guide wire, which has only floppy tip, and rest of the guide wire is very stiff. In stiff wire, it gives the strength for you to dilate. If the Terimo wire is there, it is very difficult for you to dilate because it has no strength. For dilatation, you need to have a strength in the wire. That is the second aspect. Previously, there was an instrument called as lumbotome, which we have stopped using it because there are disadvantages of using that lumbotome. But it is something like a fan-shaped blade which you pass over the wire, and it has got a blades and go right up to the kidney surface. But looking at the fluoroscopy, you don't know where the kidney surface, and people used to pass it right deep inside. And with that process, a lot of patients had bleeding, AV malformations and things like that because it was actually cutting it. So that lumbotomy disca is gone away from the instrument this. But sometimes in a fibrous tract, it is useful. But from our experience, if you use the rigid dilators and a sequential dilators, it will be possible.
So second question, large dilated system, uh, everything puncture, dilatation is easy. You have gone inside. Before you take the nephroscope and go, the ampulla sheath comes out, sir, in a hugely dilated thin parenchyma system, where densely impacted upper PUJ and ureteric stone.
Correct.
Uh, any tips to avoid this?
Yes.
Like you have dilated, you have gone, the moment you change, all the water will come out. By the time just it might come out and the system collapses, it is very difficult to go back into it.
Correct.
And even next puncture is very difficult.
Correct.
And the stone is not in the periphery, it is at the PUJ.
Correct.
You can't do stone failure at all.
Correct. Correct. I think you have described it absolutely. This is a big challenge, and exactly what you have described happens. Because it is a dilated system, the parenchyma is thin. There is no hold on the ampullates. Ampullates in the most of the cases does not come out that freely, simply because there is a thick parenchyma which keeps on gripping the ampullates sheath, and that does not allow that ampullates to come out so easily, make the movements in and out so easily. But in a baggy kidney, where there is very thin parenchyma, the ampullates movement is so easy that without even your knowledge, it comes out. So most important thing here is the safety wire. When you know that you are doing a PCNL of an impacted system at a PUJ, your puncture is proper, you keep a safety wire which is outside the ampullates. Inside the ampullates, the safety wire and everything will come out. But once it is outside this and enough thing is coiled up inside, even though the ampullate slips, your puncture is already there, your wire is there, you just dilate over that. So safety wire is immensely beneficial in a situation like this.
Yes, sir.
If it does not come out, then what you do, because you have dilated the system and it was, you know that it is a thin parenchyma, baggy pelvis, immediately in the same track, go with the rod. Don't go with the needle. Go with the rod, follow the track which you have dilated, because that's a blind tip rod. And if you follow very gently that, because there is no parenchyma, it will suddenly slip into the pelvic calyceal system. So that trick can be applied.
Okay. Sir, third question is, sometimes when you are doing a pick out stone, where you have dilated up to 18 French, normally during PCNL first 3-4 minutes there will be blood. After that ampulla sheath compression will be there. Vision will be better as the stone is removed. But when you come out immediately, does it cause more bleeding than normal? Like you have gone inside around 1 centimeter stone, you picked out and take out the ampulla sheath. If you put by chance nephrostomy, slightly it bleeds more. Does it have any relevance?
No, it doesn't.
Less than 5 minutes you have finished the case.
Yeah, I know. So it doesn't have much relevance, because eventually what happens is that the bleeding is not going to be prevented by the duration of ampullates which was there in the tract. So that has no correlation. There is no correlation that if you keep ampullates or whatever tract sheath or whatever sheath you keep, 1 minute versus 5 minutes versus 25 minutes versus 45 minutes, and there is a change in the amount of bleeding which is going to take place. The moment you remove the ampullates, whether it was there for 5 minutes or whether it was there for 10 minutes or whether it was there for 1 minute, the bleeding, transient bleeding is bound to be there. And that bleeding is going to be stopped just by the compression of the rest of the parenchyma over that tract. So it has no relevance. Even if you finish the case very fast, you still can do tubeless without any problem, without any hesitation.
Sir, for fifth question, if we have a peripheral large stone, we think that it is easy, we can touch the stone, nicely it is felt, but there is no space, like a diverticulum. Diverticulum at least will have space. Correct. But an impacted stone in the lower pole, particularly, you cannot pass any guide wire. Correct. Clearly, we try to keep some guide wire and somehow we pass the Alken rod. If the Alken rod touches the stone, okay. If he is senior, he will maintain that. Correct. For a junior who is in the beginning of the career, If the guide wire is not coiling or not going into the PCS, what are the tips you will tell, sir?
Okay, so that's a very very common problem which face, and in a compact calyceal peripheral calyceal stone, when we teach our residents, there are certain tricks to be applied to be done. First and foremost, that you are sure that you have hit the stone. You can feel the stone with the needle. When you inject the contrast, it is going into the pelvic calyceal system, but the wire doesn't go because it just hits the stone. So what you do for the wire to go, first and foremost, always use the Terimo wire, which will find its way to go there. That is one. Secondly, when you want to pass a wire, inject about 10 cc's of saline very fast. Inject 10 cc and immediately pass a wire. What happens is that in that transient half a second or a 1 second, there is a space which is created because fluid will create a space around the stone somewhere where there is a space because fluid is going inside the pelvic calyceal system, and immediately if you pass a wire in that transient half a second or a 1 second, the wire will find its place and it will go into that system. That is second. Thirdly, when you are not getting the wire is not going, what you need to do is that tell assistant to keep on injecting saline from the ureteric catheter. Obviously, from the needle you are getting saline, but the wire is not going into the system. Is not going into the pelvic calyceal system. It is hitting the stone. So gradually on fluoroscopy, what you need to do, keeping the constant flow of the urine of the saline from the ureteric catheter, angulate the needle little bit under fluoroscopy watch, making sure that fluid is coming constantly. Because what is happening is that your angle of the needle is such that there is a stone in front of it. Keeping the needle touching the stone, you can feel the stone, touching the stone, you rotate, angulate little bit so that you are now trying to go into the periphery of the stone, and then constantly keep on pushing the wire that will find the space.
Yes, sir.
The next trick is that if all these tricks they fail, then you keep a wire till such time till whatever wherever it is going. It may be remaining outside or it may be just inside, and quickly dilate up to that tract. Now you are dilating, actually your tract is outside the pelvic calyceal system because there is no space. Now moment you go inside, you will find everything is red because you are actually outside the system, but you know that you have dilated right up to the stone. Now here it is very important to give a little bit high pressure from the irrigation. Try to locate the stone, and with the lithoclast or with the laser, break the stone. Even though the vision is poor, break the stone and create a space. Don't just keep on breaking the stone because you are able to see the stone. Break the stone to little bit extent and again try to pass a wire. Every time after one or two breakage of stone, try to pass a wire. Once you pass a wire, now you are safe. Now you dilate it further. Now take your time, create a space, and then go into the pelvic calyceal system. So
excellent.
these are the 5 tricks which you have to make.
That's a very good point, sir. Sir, sixth question: if a very good calyx is there for the stone removal, access wise, you punctured, somehow fast injection of the contrast is done, needle has come out and that contrast has leaked, and the total calyx disappeared now. It was the best calyx to remove the stone. Not very big stone, not very small stone. Then you have only options, 2 other calyces. You are not confident that other calyces are so easy to remove the stone, whether it is upper or lower or middle. For example, middle calyceal puncture, contrast extravasated. This is actually question online asked. In that case, what is your suggestion? How will you go your judgment in difficult case?
So what you need to do is that when the contrast gets extravasated, it will actually the contrast in the calyx will disappear because now you are seeing only extravasated contrast.
Yeah.
So what you need to do?
Sorry to interrupt. Is it that better you use dilute contrast or thick contrast? What is your experience? Whenever you start PCNL, easy case or difficult case? Any first point? Sorry to interrupt.
Always dilute contrast.
Always dilute contrast. Okay, sir. Please.
No concentrated contrast, because concentrated contrast will have a lot of other disadvantages also.
Yes,
Because
yes.
it will not allow you to see the stone. Boundary of the calyx will not be proper. In the dilute contrast, you will see lots of things which in a better way. So always use a dilute contrast. Now, if the contrast has extravasated, actually what happens is that the contrast in the pelvic calyceal system goes away, because you are irrigating from the ureteric catheter or something like that. But the contrast in the outside will remain. So
Yes.
what you need to do is to just give a time. Even with the time, the extravasated contrast also will get diluted, because it will go into the various tissue levels.
Okay,
In
okay.
the gyrotas fascia, in the fat and this, that. It may not happen in 1 minute, but if you wait for 5 minutes, you will realize on fluoroscopy also that whatever fluid contrast which was there, actually, because extravasated contrast will not remain as a blob there. It will seep up into the fat and the fascia and other things. Eventually, that also will get diluted. And once it gets become the faded on the fluoroscopy, then you put the contrast from the ureteric catheter. If there is too much of a puncture, leakage, and other things, that contrast also will leak outside. But when you are putting the contrast into the pelvic calyceal system, it will also visualize the calyx. Now, that momentary visualization of the calyx, you have to quickly puncture.
Okay.
So, extravasated contrast, give time, let it get faded up, then inject the ureteric, do RGP, inject the contrast again, and quickly achieve that puncture which you thought was the best calyx.
Sir, seventh question. Supracostal puncture. Lot of people are afraid. When you are doing it, a common question asked is, should we tell the anesthetist to stop the respiration? One question. Number two, your entry point, should it be above the rib, upper part of the rib, to avoid the vessels? Number three, if when you are going medially uh, in the supracostal puncture, can you take chance of going on to the medial side of the calyx in supracostal puncture? These are the, like, you are not getting an angle for the lateral side, so can you go medially because it's a compound calyx? These three things.
Okay. So,
Supracostal puncture, few tips, sir.
yeah, few tips about supracostal puncture. First and foremost, we are doing supracostal puncture very, very liberally. I mean, just going supracostal, we don't even bother, we don't even think, because we always get the lateral. Our entry point is always lateral. Why it is lateral as compared to many other people? If you see all our people, our entry point is always lateral, because we are doing ultrasound guided puncture. Ultrasound guided puncture is generally you get a proper calyces
No,
orientation
sir. We
only
wanted to
lateral.
listen fluoro guided only,
So
sir.
I'm just telling you that,
Sir.
so when we are not using ultrasound, we still prefer to make that line only as the entry calyx. Okay, that is one.
Lateral.
Now lateral. Now going above the 12th rib laterally, absolutely no problem at all, because the pleural reflection is well above the 12th rib. If you go supracostal about 12, laterally, you don't have to even bother about this. Just treat it as any other normal case of PCNL. Just forget about the fear of pleura or anything. That is one. If you go medially, that is going to be a problem, because medially, if you see, the pleural reflection will touch the 12th rib. And if you go medially, then you are likely to injure the pleura. That is second. Third aspect, there is a lot of confusion about the inspiration, expiration, holding the breath, deep inspiration, expiration, what is the correct thing and what is the thing. If you go above the if you go above 12, there are two things. Transpleural, which can happen. So you are not injuring the pleura, but you are injuring only the you are not injuring lung. You are injuring the pleura. When you are making the inspiration expiration, it is only the lung which moves. The pleura is fixed. Pleural reflection is fixed. It is an anatomical landmark. Come what may, it is fixed. There is no movement of pleura. Pleura is fixed, irrespective whether you are deep inspiration, expiration. It is only the lung which you are worried, and that is where the thinking comes in. If you make deep inspiration, actually lung is touching the border of the pleura, which is harmful. Because transpleural, there is no problem. You just put ICD or many times, it doesn't matter also. But if you injure lung,
Yes.
it will cause hemothorax, it will cause a lot of problem. So that you don't want. So it is not appropriate to tell patient or tell anesthetist that you push the deep inspiration, because you are not making movement of pleura. Pleura is going to remain where it is. It is only that with the deep inspiration, if at all you want to, we are talking of only supracostal puncture, the lung movement is going to go up and down. So just don't bother. You see, it is not, in fact, if lung comes up to the border of pleura and if you are medial, there is a chance that you are actually hitting the pleura also and you are hitting the lung also, which is not correct. Now, having said that, with the deep inspiration, what happens is that even the retroperitoneal structures go down, and therefore, when you are infracostal, your kidney also comes down, and you are likely to access that kidney below the 12th rib in a better way. So, if you want to,
Yes,
this
sir.
is about the infracostal puncture. Supracostal, it doesn't matter. If it is infracostal,
Okay.
below the rib, then bringing down the kidney down has value, because remaining 12th rib, below 12th rib, you can still access the upper or middle
It's
calyx.
the upper twist. Thank you, sir. So, ninth question. In the many of the juniors are there in the forum. When you are going into private practice to deal all types of stones, now there is 12 degree, which is 12 French, 15 French, 18 French, and 22 French nephroscopes. Generally, which one will serve? Most of the times, the purpose is it 18 French or 15, or what do you recommend nephroscope to buy in the beginning? Later on, you can have any number of scopes. For a beginner, what scope to buy?
So I feel if a person in the beginning of his practice wants to buy only one scope, which should serve his purpose. I mean, purpose means what? He is going to get the bigger stone also, and he is going to get the smaller stones also. So it should serve the purpose of conventional PCNL. It should serve the purpose of mini PCNL. So I feel in a given situation, 18 French nephroscope is the best suited nephroscope if you want to buy only one scope, because still it can be used in the 20 French tract, which strictly speaking is a still miniperc tract. And the 18 French nephroscope will have all the adult instruments will go away, meaning thereby adult lithoclast, adult forceps, all these things will go from the 18 French nephroscope, which has got the 18 French telescope nephroscope, which has got the 11 French channel. So if you want
Yes,
to
sir.
buy only one nephroscope, it should be 18 French.
Okay. Sir, in the last question, lot of the students who pass out MCH and DNB may not be adequately trained in PCNL, because some of the units do less work, some of the bosses might have not taught. So, in your experience, when you train the students, what type of training is it? That going and assisting a good PCNL surgeon for 3 months, number one. Number two, seeing lot of videos and listening to lectures, or number three, practicing on the simulators, which so many have come now. In your vast experience of training the residents, apart from their intrinsic skill, because it's a training, you are working in a training institute where your wide variety of people will come, including not only the DNB students from your place, other place also. What do you think? Is it worth the student should spend 3 to 4 months of time with a good PCNL surgeon, or other methods that help the students to learn PCNL? Because it's one of the technically demanding, common bread and butter surgery. That's why continuously 100, above 100 are watching the program. What is your opinion, sir?
So I agree with you, and there are 2 3 aspects, and I will elaborate on that. That a person who is actually in the training, when they are in the training period, I always tell our residents that what is more important when you are actually learning in 3 years period in PCNL is to understand the concepts of PCNL. if you understand the concept that why you have made 30-degree, why you have made this, how you have adjusted the angle, how you have adjusted and understood the depth of the needle and things like that. Rest of the thing, cutting and breaking the stone and taking out is this. It is just a practice. But if you understand the concept, that is more than enough. Then once you go into private practice and once you have your own patients, then you can learn those things, and ultimately it is the number of cases which you do yourself is going to matter. Now, having said that, we get many observers from various other countries who have no exposure of PCNL at all, and they want to learn and go. They want to go back in their countries, Africa, Gulf, and this that. There are many people who have come like that. They want to learn and they want to practice PCNL there. Now, how I advise them is that they come, they stay for a month, they keep on watching, they keep on understanding how exactly we have done. We solve their doubts. They have to be enthusiastic. They understand. Now, when they go back, they start doing it. Having understood that, they face problem. And they keep on asking on Facebook and WhatsApp and this, that. I tell them that you select the simple cases, dilated system, simple stone, no complex calyces and things like that. Now, once you start doing such cases, you get confidence. Your other steps become you become perfect in the normal steps, and then you go to the complicated case. Having said that, once they understand what problems they are facing, I tell them that you go back, practice in your own situation, in your own patients, do that for 2-3 months, come back again, spend time again with us. Now, once you have come back, you are better to learn, because there are many points which you may have missed in your first visit, because that time you would never realize that these are the problems which are important, these are problems which you are going to face. Now, once they start doing their own and having failed a few cases, they know that I was having this difficulty. So when they come next time, they ask that, no, I was having this difficulty, so how to overcome that problem? So then we tell them that, okay, this is a problem, this is how you face this is how you overcome this. Then they go back. Now they still do more complicated case. They come back. Now they see more complicated cases. And I have seen that there are many people who keep sending us the emails and is that they are doing regularly PCNS in their country and they have become expert. So if that is possible for a person who doesn't have any exposure, it is very much possible for our own residents who actually get exposure, and then they have to go back into the practice and then do themselves.
So with this, we will conclude the session, sir. I once again thank you very much for sparing your valuable time today. Definitely it will be a memory for us and as well as the group members. And this link will be there with the group forever. As long as the group is there, I hope it forever. Then they can relook, and then especially the small tips and tricks in the video schematic representation was very good. I have not seen that JED before. After listening so many talks of you, again it was looking new, where you imagine and inside you turn. When you remove it, the needle will be bent like this. That dilatation is very difficult unless you are very lucky. First alkan has gone, otherwise it kinks inside the kidney, and the guide wire also kinks. Then entire puncture goes waste. So these type of things we learned, sir. Thank you, Sabnis sir, for your very excellent lecture in a short period of time. Thank you, sir.
Thank you very much for this opportunity.
Thank you, sir. We will close the meeting, and we can discuss in the group any doubts are there. Sabnis sir is also in the group. He will clarify. Thank you. Thank you all.